ஒவ்வொரு ஸ்டேட்டுக்கும் ஒவ்வொன்று தமிழ்நாடு மெயின் சென்டரா வச்சுட்டு சப் சென்டரா வந்து ஒவ்வொரு ஸ்டேட்டுக்கு மணி சார் அவருக்கு முதல்ல அதுக்கப்புறம் பார்த்தா ஒவ்வொரு ஸ்டேட்டாக நான் எல்லா ஸ்டேட்டுக்கும் பிளான் பண்ணுறேன் எவ்ரி மந்த் சார் செகண்ட் சார் ஓகே நம்ம இங்கே அந்த லிங்க் வந்து அனுப்பிச்சிருவோம் Okay. One minute.
Hello, hello. Check, check. Hello.
ரமேஷ் சார் கேக்குதா? ஹலோ கேக்குதா சார்? சரி சார், உங்க வாய்ஸ் மட்டும் கொஞ்சம் செக் பண்ணுங்க. அந்த மாதிரி சின்ன ரெண்டு பேருக்கு கிளாரிட்டியா இருக்கு. வெளிச்சர்னா நல்லா அங்க பேசுறாங்க ஆடி நம்ம ஆடியோ கேட்குதா கேளு. எங்களோட ஆடியோ கேட்குதா? ஹலோ செக் 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 செக். இப்போ ரமேஷ் சார் கேட்குதுன்னு சொன்னாரு.
Ramesh ji, you are audible.
சார் நீங்க பேசுறது வந்து எனக்கு கேட்கல. Madurai side is no issue. I think it's the Chennai side.
ரமேஷ் சார் கேக்குதா? ஹலோ 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 ஹலோ
ராஜ்குமார், இப்ப நான் பேசுறது கேக்குதாங்க? ஹலோ
ஹலோ
ஆ
ஹலோ
ஓகே. ஹலோ ஹலோ செக். நான் பேசுறது கேக்குதா? ஓகே ராஜ்குமார். ஓகே, we'll start our meeting. Okay. Okay, we'll start. ஹலோ. அப்படியா சார்? அப்படியா சார்? லேட்டா பண்ணிக்கலாம்.
ரமேஷ் சார் கேக்குதா நான் பேசுறது உங்களுக்கு?
கேக்குது கேக்குதுமா.
கேக்குது. நீங்க கொஞ்சம் வால்யூம் மட்டும் ரைஸ் பண்ணுங்களேன்.
கொஞ்சம் ஏன் வால்யூம் கம்மியா இருக்கா?
ஆமா, வால்யூம் கம்மியா இருக்கு சார். கொஞ்சம் ரைஸ் பண்ணுங்களேன்.
ஹலோ. ஏன் வால்யூம் இருக்கா உங்களுக்கு?
இன்னும் கொஞ்சம் ரைஸ் பண்ணுங்க சார்.
ஹலோ.
சொல்லுங்க சார்.
ஓகே, நான் பேசுறது கேக்குது இல்ல?
கேக்குது 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 கேக்குது.
ஓகே, ஃபைன் ஃபைன். Okay, we can start. We can start. Yeah, that's all right. So, good afternoon, Professor Thanapan. Ramesh. அவர் பேர் இன்னொருத்தர் பேர் பக்கத்துல இருக்கிற பேர் Professor Thanapan, able to hear me? கேக்குதா? கேட்கலையப்பா. Professor Thanapan, able to hear me? Able to hear me? இல்ல. Professor Thanapan, you are able to hear me? கேட்கலையே. அவ்வளவுதானமா? அவ்வளவுதான். சார், டாக்டர் தானப்பன் சார் கேக்குதுங்களா நான் பேசுறது? கேட்கலையே நமக்கு. ஹலோ சார், கேட்கவே இல்லையப்பா அவங்க பேசுறது. எங்கப்பா கேக்குது ரமேஷ்? ஹலோ. லாஸ்ட் டைம் இதே தான் பண்ணேன்
சார். குட் ஆஃப்டர்நூன் சார்.
குட் ஆஃப்டர்நூன் சார் தானப்பன். குட் ஆஃப்டர்நூன் ப்ரொஃபசர் பதீர் குமார். Able to hear me?
Yes sir.
Good afternoon to you all. So, at the outset, I wish to thank Department of Orthopedics, Madurai Medical College, for joining us in this endeavor of teaching the postgraduates. The entire country postgraduates, they are all interested in learning the clinical examination from Madras Medical College as well as from Madurai Medical College. So when the professors join, when the learned minds join, and when கேக்குதா?
Yes sir.
Okay, so it'll be, and they find it very useful. So for the past 18 programs we have been doing, and more than 1,000 people are joining throughout the country for this. So I hope that you have a long case there, which you will be discussing, and we'll also be interacting and clarifying few things. And here also one postgraduate is having a long case. So before we start, Gopi wants to say something before we start.
Sir, good morning, sir. Tanapan, sir. Good morning, sir. Sir, கேக்குதா sir?
அவங்களுக்கு வீடியோ அங்க அவங்களுக்கு காமிங்க.
No,
Hello?
no, we couldn't hear you, clearly we couldn't hear you.
நான் clearly கேட்க மாட்டேங்க.
The audio is not very clear.
Audio is not clear.
அவரு மதி. Sir, கேக்குதா sir?
இல்ல clear-ஆ கேட்கல.
Simply okay. Can you still improve your audio quality? Is there any possibility?
Audio volume. Audio volume increase பண்ண முடியுமா?
Video is okay, but audio quality is so poor. Interrupted quality again.
உங்க ஆடியோ எங்களுக்கு கிளியரா கேக்குது. உங்களோட ஆடியோ எங்களுக்கு கிளியரா கேக்குது, பட் எங்களோட ஆடியோ உங்களுக்கு கேட்கலன்னு நினைக்கிறேன். சரியா?
Sir, கேக்குதா sir? Sir, கேக்குதா?
No.
உங்க ஆடியோ
No.
கரெக்ட் பண்ண சொல்லுங்க.
Please raise your decibel.
ஆஹா. இல்ல. இப்ப நாங்க மத்த எக்ஸ்ட்ரா சவுண்ட்ஸ் எல்லாம் குறைச்சிருக்கோம். இப்ப உங்களுக்கு ஏதாவது இம்ப்ரூவ் ஆயிருக்கா இல்லன்னா அதே மாதிரி தான் இருக்கா? இப்ப நாங்க எங்களோட வாய்ஸ் குவாலிட்டி.
இப்போ பெட்டர்.
Now it is okay.
Now it is okay?
Okay.
Right. I think இப்ப
Hello sir, கேக்குதா sir?
அது கேக்குதா இல்ல அந்த இது கேக்குதா? இல்ல இது கேக்குதான்னு இந்த பிக்.
When Gopi talks through column mic is not able to hear. It is of poor quality.
Sir, கேக்குதா sir? Sir, morning sir. Sir, regarding sir, Professor sir, Singarudu sir வந்து retirement ஆகுறாங்க இல்லையா அந்த month. So this is the last review meeting and the last teaching class for us. So we planned a small celebration. So cake cutting and also PGs want to represent their willingness and ஒரு சின்ன ஒரு intro மாதிரி கொடுத்துட்டு இந்த கிளாஸ் ஆரம்பிக்கலாம்னு சொல்லிட்டு PGs விரும்புறாங்க சார். So just few minutes, 5 to 10 minutes. You are also நீங்களும் அதை பார்த்து கொஞ்சம் encourage us, right? Thank you sir. Thank you.
Yes, sure. Go
Yes.
ahead.
Yes.
I think lot of things they have written about me. It's all right. So we'll not waste time because since the professor's time are also there in the afternoon, without much ado, they have. என்னமா எழுதிருக்கு your one cut up. Yeah. Behalf of everyone. I really wish to express my heartful thanks to all the postgraduates and all those people who are involved, especially Gopi and all the rest of the people, for making this really a very emotional and a great occasion for me. Thank you so much for everything. So I'm just handing this over to Professor Tolgapian, who will be taking this further from here. Thank you so much. Thanks for everything. You are making my life very beautiful. Thank you. Thanks for it. Like we'll go ahead with the program. So, our first question.
Yes, sir.
Why this time? இன்னைக்கு என்ன அன்னைக்கு இருக்குல்ல புதன்கிழமை வரைக்கும் இருக்கு என்ன புட்டி அப்படியே விட்டுருவீங்க நீங்க சீப் எல்லாம் வருவாங்கப்பா என்ன அப்படியே விட்டுற மாட்டாங்க ஆடியோ நல்ல வருது ஆனா இந்த Oh, wow. Now we'll go ahead with the discussion. I request the student from Madurai Medical College to start his presentation.
Yes, sir.
Yes, please.
Yes, students are ready with the presentation, sir, and we'll start the presentation.
Please be seated. Yes. Yes.
Good afternoon, everyone. My name is Rajkumar, and I'm final year orthopedics postgraduate from Madurai Medical College. I'm here to present a long case of hip. So, a 43-year-old gentleman who is a mason by occupation.
Do you need that slip of paper? You can just start presenting without that. Yes.
Okay. 43-year-old gentleman who is a mason by occupation came with chief complaints of pain in the right hip for the past 5 months. The patient was apparently normal 20 years back, after which he sustained a low traffic accident with head injury and he was unconscious for 3 months, during which surgical procedure was done in his right hip. The details of the surgical procedure was not known by the patient, after which the patient underwent native treatment with the traditional bone setter with the native bandage for 10 days. The bandage was applied from groin to mid-thigh, after which the patient developed painless limp for the past 20 years. He was able to do all his daily activities except sitting cross-legged, and he was also able to squat with some difficulty. He was able to climb stairs, and for the past 5 months, the patient has severe pain in his right hip, for which he presented to us. And the pain was insidious in onset, and it is non-progressive, aggravated in the morning and relieved with rest. The, the patient has a dull aching type of pain, and it is associated with the limb in his right lower limb. There is no diagonal variation. There is no radiating and referred pain. Right now, the patient is not able to climb stairs. He's not able to squat. He's not able to sit cross-legged. And the patient also has limping for 20 years, which was initially painless. Right now, the limp is associated with pain, and it was insidious in onset, and it is non-progressive. So,
Why do you want to say the limp is insidious in onset? So it was following the bandage when he started walking, he started having limp.
Yes, sir.
Then don't routinely say it as insidious in onset. It was following trauma. Before that, he was walking normally, correct?
Yes. Yes. Sir.
Okay. Okay.
No history of fever, no history of weight loss, no history of loss of appetite.
No, before going into that, so what was his occupation? What is his age now?
His age is 43, sir.
43. At the age of 20, he sustained this injury.
23, sir. Yes.
Yeah, 23. Right. What is his occupation now?
He's a mason, sir.
Mason. So is he able to do the work, masonry work now?
Before 5 months, he was able to do his work, sir. He was doing his occupation. But right now, for the past
He's not
5
able to.
not able to.
Right. So the distance, walking distance has reduced.
Yes, sir.
Walking distance. How much is able to walk? Because you have to quantify that.
Okay.
So what was he able to do before? What restrictions has happened now?
Before, he was able to climb stairs. He was able to squat with some difficulty, but he was able to not sit cross-legged. But right now, he's not able to climb stairs. He's not able to squat. He's not able to sit cross-legged.
He's not able to, even with difficulty, he's not able to sit cross-legged. So
Yes,
these
sir.
are his difficulties.
Yes, sir.
Okay. Right. You proceed. So there is no fresh history of, right, you finish and then we'll ask. So these are the complaints and the presenting illness. Okay.
So,
You continue.
thank you, sir. No history of fever, no history of weight loss, no history of loss of appetite, no history of early morning stiffness for the joints, no history of multiple joint pain, no history of burning micturition. Past history is not a known case of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, no history of seizures, and no history of any drug allergy. Personal history, he's a chronic smoker and alcoholic for the past 20 years. Treatment history, the patient had only one history of surgery, that was after his RTA, and then nature of surgery and the surgical procedure done was not known by the patient. Drug history, the patient has contact dermatitis, cement allergy, for which he consumes over-the-counter drugs for the past 20 years. And since for the past 5 months he's not going for his work, he's not on any drugs for the past 5 months.
Now 20 years, what drugs? You're not able to understand that.
He just said that he consumed over-the-counter drugs for itching.
Oral?
Over-the-counter drugs, sir.
Over-the-counter drugs for what? 20 years he has been taking.
Yes, sir, for itching, cement allergy.
Cement allergy.
Yes, sir.
Okay, he has been taking. 5 months he has not taken.
5 months he's not.
Okay, he doesn't know what drug it is.
Yes, sir.
Every day he used to consume.
3 days per week.
Okay.
Whenever he goes for work.
Whenever he goes to work. Okay, right.
Development history. Development history is
விட்டுப்பா இருந்துச்சுப்பா we don't want அது பெருசா வேணும்ன்றியா பின் ஏதாவது ஒண்ணு போடு ரைட் ஒன் yeah tell me
general examination. The patient is
no now we have finished the history from this what do you want to
case summary.
think so what was the surgery which was done any implant was applied or not that they will be knowing
No implant was applied, sir.
no
there is
implant right
Actually, we took a
Case summary.
but after the surgery.
after the surgery
That looks little different. Clear, no?
so what was the surgery we don't know
Ah.
injury and then he went for a native treatment we don't know what it is so once he started walking painless limb was he noticing any shortening
Yes, sir.
he was noticing shortening
Yes, sir. He was able to
so
walk.
huh?
He was walking with limb, sir.
No. That is all right. In his complaints, sometimes the patients may not be coming with that history.
Yes,
So
sir.
after he started walking, was he noticing that the limb was short? Was he also complaining in addition to the limb? Was he also complaining of shortening of the limb?
Shortening is not
He
a
was not.
complaint, sir.
Right. So
Yeah.
even if you asked, it was not there. It was not a gross shortening. Okay. Right. So what do you think it is we are dealing with? From the history, whatever you.
Hello.
Case summary, sir. A 43-year-old gentleman Mason by occupation,
வந்துரும்,
complaining of right hip pain.
No, you need not say everything.
6:30 மணிக்கு
So from this, because we understood what it is,
Yes, sir.
so what is that you are thinking at the end of the history? What
Etiology,
are the possibilities you want to keep in mind?
so post-traumatic etiology, sir.
Okay.
So you said something about the intake of some allergic drugs, no?
Yes, sir.
Is it, do you think it is significant at this stage?
He's also an alcoholic.
You said alcoholic history and you said chronic over-the-counter drug intake. You have elicited that. You want to give any importance for that?
Yes, sir. If the over-the-counter drugs which he consumed was steroids, and considering the smoking history and alcoholic history, this might be a case of avascular necrosis.
No. Let us not go into it. So these are the things which you will keep in mind. One is trauma to the right hip. 20 years he has been limping. So there need not be any other cause for. And second is now the patient, because from the time he has been limping, there is something in the trauma which is very significant, which has produced post-traumatic problem. And second is now he is also having a history of alcoholism and drug intake that
Yes.
also can super add. So
Yes.
you want to think in terms of after 20 years, possibilities are limping now associated with pain, any secondary degenerative problem of the hip.
Yes.
So broadly, when you complete the history, what you should be able to say is it an infective, inflammatory, metabolic, neoplastic, or traumatic? So this plain post-trauma, you cannot just stop because 20 years before, 20 years before, he had a trauma.
Yes.
Now he's come with limping and associated with pain.
Pain.
So this two added, so you want to think in terms of a degenerative problem of the hip joint. So in that, you have to also consider the history of alcoholism and drug intake.
Okay.
Okay? Right. Any history of rest pain and night pain?
No, sir.
Did you specifically say that?
No.
Did you specifically say? Because you have to specifically say with the stress so that because you might have said, that is why you have to write in the case sheet also.
Yes, sir.
The long case sheet is even if you have missed, if you have written the case sheet, then it is all right. So the rest pain and that you have to tell.
Okay.
Okay, right. It was there or it was not there?
No rest pain, sir. No
No
rest.
rest pain. Okay, right. Anything from Professor Tanapan and please you can give your comments before we move further. He has a mic, no? Professor Tanapan and Professor Padiyars Kumar. So are they speaking? Okay, okay.
Hello, sir.
Yeah, சொல்லுங்க.
So we should also keep in mind possibility of infection in the
Okay,
past.
5 months duration. That infection in the past.
You are not audible.
Post-infective sequelae you want to think now. The 20 years before, whatever incident which has happened, that you want to say?
Hello.
No, we are able to hear you very well. You are able to hear us? You are able to hear us? So you are able to hear us, Professor Tanapan? Because your voice is very clear. You are able to hear us, Professor Tanapan? Your voice is very clear. நீங்க பேசி பாருங்க, கேக்குதானே?
Dr. Tanapan, are you able to hear us?
You are able to hear us?
Yeah, 1 minute pause.
Your voice is very clear.
We are able to hear you well. The presentation also very clear to us. But our communication, I think, is not reaching you.
நாங்க பேசுறது கேக்குதா உங்களுக்கு? You are able to hear us?
Presenter.
இது லாஸ்ட் டைம் கொடுத்த அந்த மைக் நல்லா இருந்தது. இந்த மைக் அதே தானா? யா, நீங்க பேசுறது எங்களுக்கு நல்லா கேக்குது.
Check, check.
நீங்க பேசுறது எங்களுக்கு நல்லா கேக்குது. எனக்கு உங்க ஆடியோ தான் ப்ராப்ளம். நீங்க பேசுறது எங்களுக்கு நல்லா கேக்குது. நாங்க பேசுறது கேக்குதா? நாங்க பேசுறது கேக்குதா? இவ்வளவு நேரம் நல்லா கேட்டுட்டு இருந்தீங்களே. அங்க உங்களுடைய ஆடியோ செக் பண்ணிட்டீங்களா? அதை கேளுங்க, அங்க இருக்கிற ஆடியோ. மத்தவங்களுக்கு கேக்குதா? வேற யாராவது இருக்கிறாங்களா லைன்ல? ஆன்லைன் இட் இஸ் வெரி கிளியர். உங்க ஆடியோ ஏதாவது செக் பண்ண முடியுமா? Mic volume is good. Your audio is very clear to us.
Hello, hello.
நீங்க பேசுறது எங்களுக்கு கிளியரா கேக்குது. ஆரம்பத்துல இருந்தே நாங்க பேசுறதா உங்களுக்கு கேட்கல. You are able to hear us whatever we are speaking? அந்த இடத்துல கரெக்டா இருக்கு ரமேஷ். ரமேஷ், நீங்க எதுவும் பண்ணாதீங்க. Able to hear us now? Are you able to hear?
Check, check.
எனக்கு நீங்க பேசுறது கிளியரா கேக்குது. நீங்க அவர் அப்படியே கண்டினியூ பண்ண சொல்லுங்க, எதுவும் பேசாம. ரமேஷ், எங்களுக்கு நல்லா கேக்குதுன்னு சொல்லிருங்க. அவங்க கிட்ட சொல்லுங்க எனக்கு.
So you continue presenting.
Yeah,
நான் continue presentation. Okay.
ஆனா நம்ம கேட்க முடியாது கேள்வி. நாங்க பேசுறது உங்களுக்கு கேட்கல.
Patient is moderately built and nourished. No pallor,
நீ அதை கேட்டுட்டே இருப்ப அங்க வருதான்றது.
sinus
அவங்களுக்கு வருதா ஆடியோன்றதை கேட்டுட்டே இரு.
generalized ligamentous laxity.
அவங்களுக்கு கேட்க மாட்டேங்குது. இப்ப நான் எதுவும் கேள்வி கேட்க முடியாது.
Chest wall expansion is normal. Local examination. I have examined the patient in standing, sitting, supine, and prone position. Standing. Patient.
நாங்க பேசுறது கேக்குதா
Patient
உங்களுக்கு?
has a gross
கிளியரா இருக்கா நான் பேசுறது?
shortening of his right lower limb with the foot in
ராஜ்குமார்,
inclination.
இப்ப நான்
அவ்வளவுதான்
பேசுறது
கேட்கும்.
கேக்குதாங்க?
Oscillating nodal
Hello?
over the
Check.
the
Check.
atlas,
Hello? கேக்குதா?
nodal over the thigh. Examining the patient in supine position. Attitude. Right hip appears to be neutral position. Knee flexion, patella facing the corner, ankle in gravity assisted plantar flexion. The muscle wasting nodal over the thigh. Inspection of
இப்ப நாங்க பேசுறது கேக்குதா?
Hello?
lumbar larynx
பண்ணியாச்சு. ஹலோ
exaggerated.
கேக்குதா?
Both anterior
Hello?
superior iliac
Hello?
spine appears to be at the same level. No
Hello?
fullness, no fullness corpus triangle. No scars, no sinus, no dilated veins. Muscle wasting nodal over the thigh. Greater trochanter on the right side appears to be at the higher level. There is a primary heel cervic scar nodal over the lateral aspect, extending to the posterior aspect.
Can you just show the
Expecting the patient in prone position.
able to hear?
Both posterior superior iliac spine appears to be at the same level. Gluteal fold asymmetry noted over the right side. Mass noted over the
Whenever you are able to hear, you
with
just
the
let us know.
linear heel primary scar noted over the posterior aspect.
அவங்களுக்கு கேட்டுச்சுன்னா சொல்ல சொல்லுங்க. அப்பதான்
Palpation.
Hello?
There is exaggerated lumbar lordosis. Both the anterior superior iliac spine appears to be at the same level. No warmth. Anterior joint line tenderness present. Greater trochanter on the right side appears to be at the higher level. Greater trochanter appears to be broadened, thickened. The surface is irregular. Palpation from the posterior aspect. Both the posterior superior iliac spine appears to be at
அதை
the
அப்படியே
same level.
வச்சிருப்போம். எப்பயாவது கேட்டுச்சுன்னா அவங்க சொல்லட்டும்.
There is a hard mass noted over the gluteal region. Moves with the movement of thigh.
Dislocated.
Assessment of deformities.
அங்க அங்க அதாவது அவரை வந்து
Assessment of
கொஞ்சம் இன்டராக்ட் பண்ண
total
சொல்லுங்க.
plate deformity.
தானப்பட்ட பேசிட்டு தானப்பட்ட
Also the
பேசி
columnar plane deformity. I'll be doing a Thomas Bell leg flexion test.
இந்த பேசுறது ரொம்ப நல்லா கேக்குது. இந்த வருஷம் கேட்க
First, I will explain the procedure to the patient
ஆமா.
and I will get his consent and I will ensure that I'll be doing the examination without causing much pain.
நான் பேசுறது கேட்கும். ஆனா உங்களால இன்டராக்ட் பண்ண முடியாது. So நீங்களே கொஸ்டின் கேட்டு எக்ஸாமின் மாதிரி பண்ணிருக்கேன். So that online people will பக்கத்துல
I'll be standing on the affected side. I'll make the patient lie down on a hard examination couch. Then I will insinuate my hand behind the And then I will situate my hand behind the low back of the patient. Then I will flex the hip and knee of the patient. Once maximum flexion is achieved, the anterior aspect of the femur will hinge against the
Once you hear our audio,
scapula.
you please let us know.
This causes the lumbar lordosis to obliterate, which can be assessed by the low back of the patient touching the dorsum of my hand. And then I will ask the patient to
See to that the pelvis is not getting lifted up. Okay, that is very important. So you should stop before the pelvis is getting lifted up. Okay, yes, that is the common fallacy whenever you are doing a thoracic flexion test. Yes.
then I will ask the patient to hold the unaffected limb with his clasped hands. By this time, any residual deformity which is present in the right lower limb will be evident. And then I will gently try to extend the right hip till I can appreciate any visible movement in the pelvis, which also can be demonstrated by the patient's lower back moving away from my dorsum of the hand. And at this stage, I will stop and then I will.
So whenever you are assessing this flexion deformity, you see to that the limb is neutral. Otherwise, you will get false negative values. So always try to bring the limb to the neutral position, then assess the flexion deformity, and final tap you have to give over the thigh. So that will leave some kind of spasm. So now this is the real flexion deformity we are having. So what is the value? So he's trying to measure this with the help of goniometer.
So you all remember that if you are asked to demonstrate with the goniometer, you have to keep it over the trochanter, which is almost corresponding to the center of the hip, and then one limb on the shaft. So this is very important. Some may be asking you that.
He is saying there is no further movement at all at the hip joint. Let us see. Yes. Any attempted movement, there is tilting of pelvis. Okay, so there is only jog of movement beyond that 30 degree. Yes. Fine. Next.
Assessment of sagittal plane deformities by Perkins methods. This condition, both the ASAs appears to be at the same level. The right lower limb appears to be in adduction. So while trying to do
நான்
further
பேசுறது
adduction,
கேக்குதாங்க?
we can appreciate the visible movement of the pelvis.
கேக்குதுங்களா மொத்தமா?
என்ன இப்ப கேக்குதா?
அப்போ லேப்டாப்ல இருந்து ஸ்பீக்கர் போறது தான் பிரச்சனை அந்த சைட்ல இருந்து.
Fixed adduction. There is a fixed adduction deformity of 10 degrees in this patient. Further adduction is not possible.
10 degree
Before going for any kind of sagittal movement assessment, especially in a unilateral hip joint, you always try to relieve spasm by doing some movements like this. So that will relieve some kind of spasm. Then you assess the ASAS. In this patient, the ASAS appears to be at the same level. So for a unilateral pelvis, the good habit what I follow is you always bring this normal limb to the edge of the couch so that you need not keep the fingers over the ASAS. So this will lock the pelvis in that position. Now you can concentrate on the affected limb. So now you see there is a adduction deformity. So we will try to bring it to the neutral. You please concentrate on the normal limb. So you can see the normal limb getting moving. So There is no opposite movement at all. So already the value is measured. Now let us see, is there any further adduction? Again, only job. Few degrees of adduction is possible. Okay. Yes.
So this is a very, very useful method to check the amount of abduction which is possible in the other limb.
Patient cannot flex his hip for 90 degrees, so I will examine the patient in prone position.
As in this case, there is only fixed flexion deformity of 20 degree without any further flexion. We cannot assess the rotation with hip in flexion. So we are going to assess the rotation with the hip in available extension. So always have the habit of assessing on the normal side first, then go to the abnormal side. Okay, always assess the normal side, then you assess the affected side. Now we is looking at rotation movement with the hip in extension. Normal side, that is the left side. Yes.
Hello.
So see the amount of external.
Hello. Check 1, 2,
Yes.
3. Hello. 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 Hello.
I think one or
Hello.
for help. Somebody.
So seeing it in
Hello.
extension, keeping
he's
the patient in
assessing
prone
this
position.
external rotation with the help of goniometer
Hello.
on the normal side.
Hello. Making the patient in prone position is always the accurate way of checking the
fixed arm of the goniometer vertically, and then try to maneuver with the moving arm. Okay, so that
Hello. Hello.
So now he is assessing the internal rotation on the normal side. Again, trying to get the exact value with the help of goniometer. That's a good habit. So always using the goniometer for getting the exact value for all movements. Now we will see on the affected side. So immediately on flexion of knee joint, you can observe some form of external rotation deformity. You can see this clearly. Now let us try to bring it to the neutral, whether it is coming out or not. Let's see. It's a revealed deformity. This rotation deformity is a revealed deformity. It's not masked by anything. So we can see the pelvis is tilting. So that is the fixed rotation deformity. We will measure it.
Hello. So in this, when you are checking, make sure that the pelvis is parallel to the couch. And it is not tilted already. And the vertical limb will be exactly perpendicular to the couch.
Without any further
Hello. Hello.
So again, pelvis is getting tilted. So there is fixed erection ratio without any further movement.
Hello.
Yes.
Hello. Hello. No, hello. Hello. Audio. Hello. Hello.
Let's move on to the measurement.
Hello. Hello. Hello.
Apparent limb measurement.
அங்க கேக்குதா ராஜ்குமார்?
Hello. Still not able to hear me. என்ன அவங்களுக்கு கேட்கல?
And always try to take a fixed point like ZT sternum rather than taking a mobile point like umbilicus for apparent measurement. Again, the same mistake. You should always measure on the normal side first, then go to the abnormal side. Always have a reference value, then go to the affected side. On the normal side, it is 113 centimeters.
The affected side it is 109 centimeters.
So on normal side 113, affected side 109. So there is a 4 centimeter difference in apparent measurement. Now we are going to do the real measurement. Since already the case is displacement at the same level, so we are not going to do any squaring.
But the limb has to be kept in
High
the
length is
same
45
position,
centimeters.
identical.
The normal side.
So normal side, they are keeping it in adduction and then they are checking.
On the
So you
affected
have
side,
to
the
tell the
length is
examiner
40
also.
centimeters.
Hello. Now you are able to hear us?
முன்னாடி கொண்டு வர முடியுமா? கொண்டு வந்து காமிச்சீங்கன்னா
Okay, still not able to hear. So when you are checking the true measurement, one is to square the pelvis, second is to keep
So
the
you
limb
can
in the
see the
same position.
difference is again in the real measurement also the thigh segment difference is the same 4 centimeter. Yes.
Hello. Hello, check.
Leg length is 39 centimeters on the normal side. Leg length is 39 centimeters on the affected side.
He has made a mistake in this measurement. Any postgraduate from Chennai able to find it out, you can tell with your professor.
Check.
Otherwise, I will tell from here. So the problem here is the pelvis is squared. So there is no pelvis unsquaring. So already the right side is at the 20 degree of adduction. Isn't it? So you should always keep the normal limb also in 20 degree of adduction for real measurement. So that will give the idea of real measurement. For apparent measurement, you can measure as such. For real measurement, you have to measure with the normal limit 20 degree of flexion. 20 degree of flexion.
Check. Check testing. Check. Hello. Check. Hello. Check. Check testing.
Length is 45 centimeters.
So though there is a 20 degree of fixed
Now
flexion
you are getting
deformity,
a 1 centimeter extra difference. Okay, so in apparent you get 4 centimeter. Now you are getting a 1 centimeter difference. Okay, yes.
Check.
You are not getting the input from Singh sir and Aswati sir.
yes.
Students are missing that.
Check.
Blind triangle.
கொஸ்டின் கேட்கணும்னா சார் போனை வந்து சிக்னல் காட்ட சொல்லுங்க. நான் இங்க ஸ்பீக்கர்
அதான். Able to hear us now? இல்ல.
சார் கொஸ்டின் எது கேட்கணும்னா அந்த போன்ல கொடுக்க சொல்லுங்க. நான் ஸ்பீக்கர் போட்டு இங்க மைக் வைக்கிறேன். டாக்டர் ஆன்சர் பண்ணுவோம். சரணா.
அதான் அவங்க லேப்டாப் இஷ்யூ. So where
The blade located on the right side is at a higher level. That is reversal of right triangle. Negative. This is very well. So again, the brain triangle always you have to measure on the normal side. Then you have to compare with the affected side. Otherwise, your values will be misinterpreted.
So now they are drawing the branch triangle and trying to find out. In branch triangle is also a true measurement. So anterior iliac spine should be at the same level and the limb also should be in the same level of adduction. Then only. So if they are not able to mask the flexion deformity, then the flexion also must be replicated.
Brain staging value, what is the value of the brain staging on the left side? 4 centimeter. The base is 4 centimeter. What about the value on the right side? 3. You have 3 or minus 3. I think it's 0 only. So this side brain staging base is 0. That side 4 centimeter. So again your true measurement is 4 centimeter. So all the 4 centimeter is confining to the supratrochanteric region. So that is the value we are getting. I don't think it's just crossed and reversed. The space has become flattened. Next, intelligence line. For the sake of postgraduates, this Nelson style is very, very important because it is the only line which can be done without squaring the pelvis. So it's a very useful indicator.
So now they are attempting
from
to.
anti-superior iliac spine to ischial tuberosity. Normally, greater trochanter lies at or below the intelligence line.
It can be in any position of flexion of the hip. If hip is, you can flex it to 90 degree, it is easy to locate the
Line
ischial
ideally to
tuberosity.
be measured with hip at 90 degree flexion if it's possible. Not possible, then it is okay. But 90 degree flexion, the line drawn from the ischial tuberosity to the ASAs, the tip of the trochanter should lie at the crossing line. Okay. Better to be measured at 90 degree of flexion.
Now in this case, you can see it is grossly above the deltoid line. The tip of the trochanter is grossly above the deltoid line.
Then it is very, very clear. So please proceed. In the laptop, they can bring it near you so that the audio will be heard by them. If the laptop person can bring it. Laptop person அங்க பக்கத்துல போய் இருந்தா அடுத்து அந்த ஆடியோ இந்த மாதிரி கேட்பாங்கல்ல லேப்டாப் person அது சொல்லுங்க ஸோ அந்த லேப்டாப்ல இருந்து உங்களுக்கு ஆடியோ தான் உங்களுக்கு கிளியரா வர மாட்டேங்குது. நீங்க பேசுன அத்தனையுமே கிளியரா கேட்டுச்சு, எல்லா சயின்ஸுமே கிளியரா தெரிஞ்சுது. ஸோ அந்த லேப்டாப்பா நீங்க பக்கத்துல வச்சுக்கிட்டீங்கன்னா நாங்க கேட்குற கேள்வி என்னன்னு உங்களுக்கு வந்துருச்சா? இப்போ வந்துருச்சா? இப்போ ஓகே. யா. ஸோ கேக்குதா இப்போ?
Yes, sir. Yes, sir.
Okay. So your presentation
so far,
was.
Please go through your whatever your inputs so far.
Yeah. So you have demonstrated extremely very well. All the relevant points you have showed very well. So I was just telling few things which you have already told. The first thing was that you kept the normal limb in full abduction to see the abduction of the affected side. So that is a very useful point for the postgraduates, they must know. And using the goniometer, how to check for the flexion deformity and the rotation, you have demonstrated very well. And checking for the rotation in prone position, you have demonstrated very well that this patient is in external rotation deformity and no internal rotation was not possible. And your measurements, you are very clear in showing the apparent and true. And true, when both anterior iliac spine are at the same level, the normal limb has to be brought to the position of the affected limb. So if there is a flexion deformity, if it is masked by the exaggerated lordosis, then no need to worry. Just keep the adduction, whatever the affected side was, and then measure. But if there was a flexion deformity which could not be masked, like in an ankylosing spondylitis, or in cases which the flexion deformity is little more, then you try to replicate that flexion also in the normal side, and then try to check for the measurement. And you have showed beautifully the Nelatens line, how it is drawn, and the tip of the trochanter is above the Nelatens line. So everything is very, very clearly demonstrated from your side, and we are able to see and hear everything. You can just proceed with the final.
Next is shoemaker's line. Shoemaker's line is drawn from line connecting a greater trochanter to anterior iliac spine and extending the line to the anterior aspect of the abdomen.
I think you need not bother. It is obviously going on the opposite side and
Usually,
below the umbilicus.
yes,
Yes,
Chinese
shoemaker's line. Yeah. Since, yeah, that also both anterior iliac spine and both greater trochanter. Please draw. Okay, we'll assume that you have drawn and it is converging on the affected side. Anything else?
Next.
We'll go ahead. Yes, we'll go ahead. You just tell. What is the next?
Morris bitrochanteric distance.
Yes, how did you do? Did you do?
And measure the distance from the pubic symphysis to greater trochanter
How did you do that?
with the help of a book.
Help of a?
Morris bitrochanteric test, you need a cardboard or some book. So,
So,
without that,
right.
don't commit on
Okay.
this
Without
test.
that, don't do it. Exactly. So, very good. So, you have to keep something straight perpendicular to the axis and then draw. Okay. So, that is the way it must be drawn. So, everyone, these are all things which are very important. In case of protrusio, it is very, very important that the trochanter would have gone inside, and that tells two ways. One is per rectal examination, which we normally don't do, or the Morris bitrochanteric. Very well demonstrated. Yes. Next. What are the other special tests you did? And one more before we go further, in the Brandt's triangle, when you are showing, you also tell the hypotenuse distance, and don't forget to say that, because many people, if it is externally rotated, if it is gone inside, so the distance might differ. So you also make it a point to measure that aspect also. Some examiners might like it. Okay, right. Next, final.
Special test, Trendelenburg test.
Yes. Is the patient, did you do the Trendelenburg?
No, so the patient is not able to
Okay.
stand with the affected limb for more than 30 seconds.
Any fixed deformity, especially adduction deformity, you should not do this. That is the answer. Whenever there is a fixed deformity, so that's absolute contraindication for doing a Trendelenburg test.
So when the patient has to stand, even if he is able to stand, weight bearing on the affected side, if there is a 20-degree of fixed adduction deformity, when the patient has to stand, then he has to sag the opposite side for standing perpendicular. Then the other side will sag down only, sound side. So that doesn't mean it is positive or negative. It doesn't tell us anything. Okay. So fixed coronal plane deformities, you must not do Trendelenburg. In addition to not able to stand for more than 30 seconds, you need at least 10 to 20 degree of adduction, free adduction and abduction from neutral position. Okay, next.
Telescopic test.
Yeah. What was your inference?
It's not possible.
Positive. Can you just show us?
Telescope is not possible, sir.
Not positive. Okay, that's all right. Because it is so stiff, I'll be surprised if it is positive. So it is not positive.
Not possible.
Okay, then
Parental examination.
yeah, you didn't do. No, you just continue, complete. Okay. May not be that relevant. So gait. Yeah, before going for that, did you mention about, because some things which were not very clear, femoral pulse, did you mention in your palpation?
Bilateral femoral pulse equals.
Equal. So vascular sign of Narath was negative.
It's negative, sir.
Negative. So there was a mass in the gluteal region which was moving on attempted movement of the hip. Correct?
Yes,
Okay. So these two are the findings.
yes.
So you have to be very, very careful when you are establishing your diagnosis, what it is. There is a mass in the gluteal region which moves, and vascular sign of Narath is negative, and femoral pulse is equally felt.
Yes.
Make doubly, triply sure. Okay?
Yes.
You understand the significance. Okay. Next, gait. Just make him walk few steps. This is the most important part. The camera person, please show the patient as he is walking. No, not this way. You tell. No. Wait. Before is right. From the front, from the back. So ask the camera person to stand in front and back, not from the side. கொஞ்சம் தள்ளி வச்சிட்டு. Okay. Okay. Nicely done. So for the benefit of the other viewers, once more, ask him to walk. Right. Ask him to stand before he walks again. You just describe the gait so that the other. No, just wait. Ask him to wait. You tell what is the gait?
Patient walks with bipedal unassisted short limb antalgic gait.
Short limb antalgic gait. Okay. So why do you say short limb?
Stance face on the affected side is
Why a short limb gait, not the antalgic? Why?
the affected limb is in equinus.
Okay, very good. Then anything else to say it is short limb? Most important.
The trunk, the deviation of the trunk is to the same side.
No, I didn't get that. Sorry.
When the patient ambulates, the shoulder
tilt is the shoulder is tilting to the same side. That is the reason. No, this is a very, very classical short limb gait, but not for the reason what you are saying. Anything else? This is a classical short limb gait. Okay, so without wasting time, both shoulders dip together during the stance phase of the affected side. When you make him walk, you just see when a Trendelenburg or anything, there will be a lurch to the same side. But in a short limb gait, if you see, every time he goes from the normal side to the affected side, both shoulders dip together and they come up. That is a classical feature of a short limb, which is very obvious in this. So when he goes down, you just see when he is bearing weight, he just dips down together and then climbs up on the normal limb. So that is one. He also has a little bit of a gluteus maximus lurch. That is, he goes backwards. In addition to going to the sidewards, he just goes little backward. But that you need not say. It is short limb because there is an equinus when he is standing. And when he is walking, he just dips both. So ask him to walk once again. You just carefully see. So now the lurch is more backwards because it is becoming painful, but both shoulders coming down and going up. So that is the classical feature of a short limb gait. Okay, right. Anything? Examination is complete. Anything else you want to say?
Examination of spine, sir.
Yes. No, you just tell. You need not show the patient. You just tell what is the finding.
Spine examination is normal, sir.
Normal. What are the things you did to say it is normal?
I look for scoliosis, sir.
Okay. Deformities, coronal sagittal plane deformity. Then
Show busters.
what is that? How much was it? Did you do? So never forget all these things. Okay. If you have not done it, it's all right, but never in the exam say something cook up. So these are things which definitely we'd like to see. How you do the show busters, please start going inside detail. Okay. Then what are the other tests? Never forget in all cases, even if it is neck of femur, you do. Then only you will not forget when it matters. Okay. Then what else?
Parental examination.
அதான் rectal முடிச்சு திரும்பி rectal சுத்திட்டு இருக்க. You have already done with rectal. So you have to say, when you are saying, you have to say posterior iliac spine tenderness, the sacroiliac joint, the distal knee joint is normal. Then chest expansion, how much it is. So never forget, because we often find students coming up mostly trying to differentiate between inflammatory arthritis and post-trauma or avascular necrosis or degenerative, not telling about chest expansion, sacroiliac joint examination, the distal knee joint. They are all very, very important. Okay. So why is examination of the spine and knee joint is important? Ipsilateral knee and spine, we always say, correct? Why is the examination important? Anybody? Tell. And இன்னொரு mic இருக்கா? இது ஆன் இருக்கா? Anybody? From there or here? You just talk.
So in case of inflammatory arthritis or seronegative arthritis, there can be involvement of the spine. And in case of inflammatory arthritis, there can be involvement of the knee joint as well.
Now that is involvement. Why involvement of the spine and the ipsilateral knee? Always one joint above, one joint below, we tell. You have to examine. Polyarthritis, you have to examine all joints.
Any compensatory changes?
Okay, very good. Going ahead further. Somebody wants to answer there? Okay. You can just raise up your hand, then otherwise I'll tell the answer. Okay. So if you are to salvage the joint, the three ways of doing it is, one is doing a hip replacement, or you can fuse the hip, or you can do an excision arthroplasty. These are the three ways of salvaging. You must not fuse the hip if there is involvement of the spine or the knee, because these are the two compensating joints. If it is involved, then you have to do only a replacement or some other which will give movement. Okay, right. Anything else? What is your diagnosis? Yeah.
So, 43-year-old.
No, diagnosis. We know. Right. Need not summarize. Diagnosis, anatomical and pathological.
Right hip pathology. Post-traumatic etiology. Pathology, secondary degenerative arthritis.
Secondary degenerative arthritis of the right hip. Is it your diagnosis? You have to commit. And you should also make a mention about the distal neurovascular deficit. Hopefully you would have done sciatic nerve, very important. Okay. So anatomical diagnosis can be arthritis or synovitis, ankylosis or coxa vara or unstable hip. In this, what will you put for diagnosis?
Your findings, you can come across a probable diagnosis. So, is there any joint line tenderness in this patient? Joint line tenderness is there, and there are fixed deformities. Okay, these 2 points are in favor of arthritis apart from shortening. But in this patient, what about movements?
Movements is grossly restricted.
So it's only jog. So the movements is grossly restricted. Only jog of movement is available, and there is fixed deformity in all planes with a gross amount of shortening. Now the possibility of synovitis is ruled out because there is real shortening, and you have to go in between other 3 possibilities. You couldn't be able to do this telescopic test. So, so that is not going to help you. So now you are left with arthritis or ankylosis, which is your more probable diagnosis.
Ankylosis.
So this is a clear way of arriving at a diagnosis. Rule out one by one. Don't be confused. Take all the options together. One is, if it is synovitis, all movement, extreme movement is painful. Not so. Arthritis, true shortening may be there, but available range of movement should be painful. There should be reasonable movement. Coxa vara, only specific range of movement which is not applicable. Telescopy, unstable hip, there should be telescopy positive, Trendelenburg positive, which is not there. So you are left with only a ankylosis in the joint, correct? So only a jog of movement is present. So in that you have to differentiate between a bony ankylosis and a fibrous ankylosis. What will you say?
Excuse me, sir. Before that, we should also give equal weightage to that mass palpable in the gluteal region, which is moving along with the shaft of femur and with the gross shortening of 4 centimeter.
Sir, in the, yes, sir. Sir, in this, yeah, definitely that should be taken in the pathological diagnosis. In the anatomical diagnosis, it is only if it is 4, we have to settle with any one of this. So it is an ankylosed hip. So there is no movement wherever it is. So the hip, wherever it is, whether it is in the normal position or in the abnormal position, it is not allowed to move. So this is ankylosed. So is it a bony ankylosis or a fibrous ankylosis? How will you differentiate? Whether it is bone which is formed across the hip.
You should have a clear idea. So how to differentiate between bony ankylosis and fibrous ankylosis clinically?
The jog of movements are possible. It is bony ankylosis.
In bony ankylosis, there will be no movement at all. Whereas in fibrous ankylosis, you will be having jog of movement. With the attempted movement is always associated with this pain and spasm. All these points are important when you are giving a diagnosis of fibrous ankylosis. In this case, is there any jog of movement or is there no movement?
Jog of movement is possible.
It is associated with some amount of spasm and pain. So now your probable anatomical diagnosis is
Fibrous ankylosis.
Okay. So when attempting to move, if it is painful, you need not bother. It is fibrous ankylosis. On attempting to move, no movement, no pain, it is bony ankylosis. Okay, it's clear? Right. From this, a pathological diagnosis. So what is the pathology you think? Probably.
"20-years-old neglected posterior dislocation of right hip."
20 years old, neglected dislocation of right hip.
Yes.
Okay. So why do you say dislocated hip?
I can feel a mass which is palpable in the gluteal region, which moves with the movement of thigh.
Okay, so what is the shape of the mass?
So it is a hard mass, sir.
Okay, globular, continuous with the, yeah, movement of the femur. It is moving. That's the
Yes.
reason why you say. Right. Any other differential diagnosis you want? Or what are the points which is against dislocation?
You are giving a pathological diagnosis of neglected posterior dislocation hip. There are some contrasting negative points towards that. You are not able to get a telescopy. In this case, femoral pulse is felt equally on both sides. So these 2 points are against your diagnosis. So we have to think of some other differential diagnosis also. Is there any other differential diagnosis?
So can you explain the absence of femoral pulse and the loss of, I mean, we expect exaggerated movement, but there is no movement. So can you explain it and tell me any other diagnosis which will fit in this clinical finding? 2 questions. How do you explain that there is equal femoral pulse? Okay, sometimes 20 years, if there is a fibrous tissue which is matured, the capsule and other things which are there, which are stretched, and the patient has been walking. He has been walking with the soft tissue support only, not with the bony support. Bony fulcrum is not there. So that has given the base for the femoral pulse you want to palpate. So that's the reason why you have to repeatedly check and you are sure that it is equal. It can be in long-standing dislocations. That is one. And second is any other differential diagnosis. This much of 5 centimeter shortening is little difficult. Otherwise, anything like a myositis mass which is there, which is attached to the trochanter, all these massages, it can also explain, but you cannot explain the other findings. Okay, so what is the attitude you expect in a posterior dislocation flip? Attitude of the limb in posterior dislocation.
Adduction and internal rotations.
Okay, what is it here?
It is a fixed external rotation.
Right. So how do you explain?
So one of the commonly asked exam questions. So whenever you are getting a pattern like this, there is adduction deformity. At the same time, there is external rotation deformity. So you have given a diagnosis of posterior dislocation hip already. How are you going to explain this external rotation deformity? Anybody from Chennai side? Any post
Yeah. So one person is telling, yeah, you're coming in. So,
Yes.
Yeah.
Extracapsular neck for intertrochanteric fractures associated.
Louder. Able to hear?
Associated extracapsular neck for intertrochanteric fracture.
Okay, associated fracture is one of the cause. Any other cause? More common cause. Otherwise, which is holding the limb in this internal rotated position? Which structure?
Anybody else? There are
Anybody
two
else?
causes. What is the cause for this, and destruction of what can cause this?
Use
Okay.
mic.
Use the mic.
Acetabulum.
Acetabulum. Yeah, that may be one of the reasons when there is an associated fracture of the acetabular wall. If it goes up, it can go in for an external rotation. That is another point. But these are not the answers what we expect. There is one more.
These are all not common. So these are all are manifested with other clinical findings also. For example, if it is a trochanteric fracture, you will be getting trochanteric thickening, tenderness.
Gluteus contraction. Gluteus contraction. No, why it should contract in that position? Why it should contract in that position? So if it is already in an internal rotation, why it should contract and pull it to external rotation? Not the answer. Okay, I think people are not aware of it. That side, anybody is aware?
Anybody from this
Anybody?
side? No, sir. You explain.
Oh, man. What happened to this one? So the cause for this is the ligamentum bigelow. So this is called as the paradoxical dislocation. I think we have discussed this before, but not remembering that. We have to repeatedly say. So this is called as the paradoxical dislocation. Ligamentum bigelow is one which holds the limb in that position. So that is the strongest ligament of our body, the iliofemoral ligament. So once that gets ruptured, then this doesn't maintain this attitude. So this can be one, either an extra capsule. So you must be able to explain something. Can be a fracture which is malunited and still maintaining this. Second can be, it can be an associated with the fracture because some surgery has been done. They have brought it to the acetabulum. Usually the head of femur, if it goes into the acetabulum, it doesn't dislocate like a shoulder, even if they go in for a native treatment. Unless it is inherently unstable, like if there is an associated posterior wall lip fracture. So if that happens, then it can also lead on to a external rotation. But the third most important what all examiners want is that the rupture of the ligamentum bigelow. So that can happen even if there is a wandering acetabulum, the treatment happening in tuberculosis, if all those places, if it gets destroyed, you don't expect the classical picture of the dislocation. So this is called as the paradoxical dislocation. Okay. So what would you like to do? We'll just have a quick one and then I have to go.
I'd like to proceed with the investigations.
Yes, what investigation you want?
Say.
Yes. So first straight away say X-ray, don't say TCT, CSR, CRP, all those things. Very good. Put the X-ray. Can you just show us the X-ray? Cameraman, please show the X-ray. So somebody is going to put or only in the mobile you are going to show? Show something. Very interesting. Very, very nice case as the time they are taking and yes.
Thank you, sir.
Can you just zoom and reduce the brightness so that you can see something?
You can read the X-ray.
Yes, yes, yes. Close up and reduce the brightness. The lower one appears little better than the upper one. Then established fracture, looks like that. Posterior wall is not seen. So கொஞ்சம் brightness reduce பண்ணி கொஞ்சம் எனக்கு அந்த close up pelvis காமிச்சா very good. Yes. Okay. Can you read the X-ray?
It is a
yes.
Plain X-ray AP view of pelvis with bilateral hip.
Yeah, please proceed with the finding.
I can appreciate there is a broken Shenton sac.
Very good.
The acetabular socket is empty on the right side.
Okay.
The shaft of the femur migrated proximally. The whole femur migrated proximally. along with the deformity noted at the proximal aspect of head, neck of femur.
No, deformity of neck of femur we can't say. But anyway, beyond that, you cannot comment anything more about this with this X-ray, right? So it is from here we know that the acetabulum is empty, Shenton's line is broken, head has migrated proximally, and your diagnosis is right. There is head which is faintly seen, which is articulating in a false acetabulum. So your diagnosis of dislocation with pain there is right. What do you want to do now? Okay, very good. Beyond that, I think it is difficult to diagnose.
I would like to take a CT scan.
Very good. You want to investigate further to understand the anatomy better. So
Yes.
here, what we suspect is acetabular fracture, head migrated up, false acetabulum. These are the things which we can suspect with some amount of myositis which is around the head, neck and trochanteric region. Right. CT we want. Let's start thing now. So CT, yeah, first go to the axial cuts above. Go to the axial cut close up. Top three alone you show. Top three alone. Very good. So you can see that the wall is fractured. Head has come out. So these are the things which as we discussed it is there. The posterior wall with acetabular fracture with head up and the myositis which is formed all around the femoral head. Okay, down. Can you just show us? Correct. Okay. Okay, now we see that there is a posterior wall fracture with the head migrated outside the acetabulum and causing articulating in the pseudoacetabulum and fibrous ankylosis there at whichever place it is articulating. Painful hip. So with this, what do you want to do?
I would like to take a MRI, sir.
MRI. Why do you want to take an MRI now? Because you have an MRI.
So I think
What?
there's no need for MRI in this patient. So already the head is completely destroyed. So you can see the shape of the acetabulum from this 3D cut itself. So I don't think MRI is going to help you further in management purpose.
So don't just tell routinely MRI. So 20 years later, what are you suspecting? And what the additional information you are going to expect from an MRI? Is more than enough. Right. So MRI head is normal. What do you want to do now?
Only manage.
Management.
Here is a patient who is having a fibrous ankylosis of the right hip joint with a 4 centimeter shortening, reasonable middle age, I think. 40. What is the age? 44. So you have to give some treatment for him. What is your aim first?
Patient actually complains of pain. So
What is your aim? Aim is very important. What is your aim? So aim means, so in the patient aim enna. So we have to give a pain-free mobile joint, and at the same time you have to tackle this shortening. அதுதான் நம்மளோட aim இந்த பேஷண்ட்டை பொறுத்த வரைக்கும். All these components நம்மளால வந்து at a time கொடுத்துட முடியுமா இல்ல இதுல ஏதாவது ரெண்டு காம்பனன்ட் மட்டும் தான் நம்மளால அட்ரஸ் பண்ண முடியுமா? We have to ask ourselves. So our aim is to have a painless mobile joint. At the same time, you have to compensate for this gross shortening. Based on this, what is your treatment plan?
Just keep talking. How are you going to give pain relief? How are you going to give mobility? How are you going to give a stable hip? How are you going to address the shortening? So there are 4 problems you have already identified. First is pain relief. What do you want to do? What can you do? What are the options? We have already discussed. Options for a painful hip. There are only 3 ways. You need not scratch your head. Which of the option you will choose? Will you choose fusion? Because if it gets bony fusion, then the pain will be totally gone. There is no joint to move. Fibrous ankylosis becomes bony ankylosis. So can you give that? So shortening, let them wear with the 4 centimeters, 2.5 centimeters, you adjust with the heel and sole rise. 1.5 centimeter patient can adjust, manage, fusion. That's a very good option. But 43, the spine already would have started bearing the brunt. Okay, so people will curse you, people will not tolerate that. Any over movement at the spine and other joints, sacroiliac joints, it is going to be very, very painful, very fast. Then you have to manage that. Right, fusion. What are the other 2 options? Tell.
Excision arthroplasty and replacement.
Replacement, right. Excision, can it be done?
So considering the age of the patient.
Right, we'll come to total lip and then go to the excision. So can you do a total lip arthroplasty in this patient?
Yes.
It can be done. What are the challenges you will face?
There's a fracture in the acetabulum, sir.
Very good. So what is the problem in that?
Acetabulum shell component placement there.
Now, what will be the problem in placing the shell component?
Since the pathology is for 20 years, bringing back the head to the normal anatomical position will be difficult.
So very, very difficult to get all the contractures released. You may have to do shortening osteotomy of the femur to get the head down. You have to augment the posterior wall with metal augment because bulk bone graft will not get incorporated. It will fail ultimately. So it is a very, very complex procedure. Okay. So total lip replacement, straight away if you say, we'll ask questions and we'll assume that you will directly advise this patient as a consultant once you graduate and go out. Able to understand that? So you must understand the complexities of the total lip at least, even if you don't know how to manage them. Bringing down the head, the reconstructing the acetabular wall and managing the shortening with 43-year-old, what is the cup and what is the stem you have to put. So all those things are very complex procedures, sir. It is not easy. So what is the option left? Can you do an excision arthroplasty? So these are the 2 options which you have to discuss. So if you just keep on thinking, you can just argue with the examiner, sir, this patient is 43 and doing the 3 salvage options. One is fusion, 43, there will be problem in the spine and knee, so I don't want to. And he also wants to sit down and mason work. He cannot continue that. Second option will be to do a total lip replacement to give him a painless, stable, mobile hip. But reconstructing the posterior wall, getting the contractures released, shortening, do a femoral shortening and specialized component, very, very difficult and technically very challenging. Third option is the excision arthroplasty. So then if the examiner wishes, then probably we'll go ahead. I think we'll stop with this because this itself is taking the discussion little too high. And probably locally we can discuss. If you are doing an excision arthroplasty, how to get stability. In addition to excision and shortening, how can you lengthen that? What is the method of fixation? There is a beautiful article of double osteotomy, how it can be done, how the stability can be achieved, and how you can gain the length also to have a near normal movement in 40-year-old. Go and read in a JBJS article. That's a very good article. Okay. So I wish to thank really Madurai Medical College, Professor Padiyarasa Kumar and Professor Tanappan for their valuable inputs. I really appreciate the postgraduate who has presented. He did a wonderful job, and half the time we were not able to interact, but he did a wonderful job in demonstrating everything. So I thank the entire department for organizing this. I hope it was very, very useful. There is another case here which Professor Pasupati and Professor Tolgapian will coordinate. I have to leave. So for another cadaver program, I am just leaving. Thank you.
Thank you so much, sir. It's a pleasure being with you. Thank you so much.
Yes, sir. Shall we proceed with the other case, sir? Dr. Padiyarasa, sir. This is Dr. Pasupati and Dr. Tolgapin from here. And Dr. Tanapan, sir.
Yes, sir. Yes, sir.
Can we stretch for another half an hour to 45 minutes?
Yes, sir. Yes, sir. We will proceed, sir.
Yes, sir. We will try to make it as precise as possible, because we are the audio system is now corrected well. Yes. Yes. Who is the next PG presenting? Yeah. Dr. Saran is presenting a case of hip case again. Is it? Okay. Quickly give the important history, and at the end of you start presenting the history. Sir, are we audible, sir?
Yes, sir.
Tarapan, sir?
Audible, sir. Audible.
Yes, sir. Yes, sir. If you want to intervene and in between any questions you want to ask the presenter, you can ask from there
Yes,
also,
sir.
no problem.
Yes, sir. Yes.
Tell the salient complaints, salient history,
Be quick.
and yeah, briefly you tell. You need not be
Hello.
elaborate like what. Yes.
Good afternoon, sir. Myself, Dr. Saran, final year postgraduate. I'm going to present the long case of.
Sir, your voice is not that much clear, sir.
Yes, just hold it in your hand.
Hello, sir. Can you
Yes,
hear me,
yes.
sir?
Now it's clear. Yes.
Sir, myself, Dr. Saran, a final year postgraduate. I'm going to present the long case hip. Mr. Susai Mani, a 38-year-old male, who is a coolie by occupation, came to Orthopedic with the chief complaints of hip pain in the right hip for the past 3 years and a painful limb for the past 3 years. History of presenting illness. Patient was apparently normal before 3 years, after which he developed pain in the right hip, which is insidious in onset, gradually progressive to attain the current severity. This is a dull aching type of pain, which is radiating to the anterior aspect of thigh up to the knee. The pain was initially relieved by the painkillers, but for the past 6 months, it is not relieved by painkillers and aggravated on doing his regular activities like climbing upstairs, downstairs. There is difficulty in squatting and sitting cross-legged. And the patient was, in terms of walking distance, the patient is able to walk pain-free for about 200 meters, after which he experiences the pain. There is no history of rest pain, no history of night pain or night cries, no history of remission and exacerbation episodes. In terms of limping, the history of painless limp since 8 years of age, for which he did not seek any medical advice. Patient was able to do his regular activities with that painless limp. For the past 3 years, patient was able to developed a painful limp, which gradually progressed to attain the current severity, and with the increased difficulty in sitting cross-legged and squatting. Patient also has the history of the shortening of the right lower limb when compared to the left lower limb, and there is no history of morning stiffness, no history of trauma, no history of bowel and bladder, altered bowel bladder habits and burning micturition, no history of any skin lesions. No history of usage of any walking aids or shoe rise, and no history of any clicking and no history of any locking and clicking episodes seen. Past history.
Yes. Tell the past history.
Past history. The patient has undergone an abdominal surgery at about 2 years of age, for which the details are not available. In terms of birth history, patient is a normal vaginal delivery. Is a second born male child, has an elder sister and an younger brother who are normal. There is no attained milestones at appropriate age, and there is no history of any ICU admission at the time of birth.
So what way you think at this stage of this presentation? Yes, this problem is only for the past 3 years, no?
No, sir. Patient has a painless limb since 8 years of age, sir.
Since 8 years. Okay. Okay then. Okay.
But family history, there is no significant family history. In terms of personal history, the patient is a known alcoholic for past 15 years. He is an occasional drinker. Drinks volume of about 180 ml per week. He is in abstinence for past 6 months. Not a known case of smoker or betel nut chewer or tobacco user. General examination.
No, at the end of your history presentation, you must be able to come to a conclusion what kind of as the broad category of thing, no? So now you can tell he is working with the limb since 8 years
of age.
Okay. Then
pain for the past 3 years, painful limb for the past 3 years. Sir.
Okay. So what you think, what is the problem you are thinking in mind? Is it a traumatic problem?
Most probably the developmental pathology.
Okay.
In
some childhood pathology, now it is going for some degeneration. This is the combination you can think in mind. Okay, we can go. Anything, sir, you want to ask?
In history, again, you are confusing between these two main complaints. So there is a pain, there is a limping. So you initially stated that both are present for the past 3 years. Then you suddenly saying that the limping is present for many decades. Again, in presentation of history, you started with pain, you suddenly moved to movements and limping, came back to pain, then you go. Be clear in your way of presenting. So if you are describing pain, describe pain, then you start the limping. So that one point. And you told that there is a surgery at 2 years of age. So details may not be available, but in which area the surgery being done, that will give an idea. So there must be some inguinal hernia or some hydrocele. These are the common surgeries which are associated with our problem. So that will give an idea to what we are going to face. So that region my patient would have known. The other point you told that patient himself is aware of this shortening. He is saying that his one limb is shorter than other limb. Is it so?
Yes, sir.
Yes. So since this is a case of limping, that is the main issue in this patient. You should elaborate further on that, like ADL. What are the ADLs that is getting affected for this patient particularly? And you have to mention about swaying of shoulder. You can ask the history in the history itself during walking whether there is any particular swaying of shoulder this side or that side. So that again will give an idea of what we are going to deal with. So these are some of the additional points.
Okay.
Yes, sir. Shall we ask him to proceed with anything you want to add after hearing the history-wise, Karan? So regarding the limb, you want to elaborate anything else?
Patient has a painless limb since 8 years of age, but the patient himself was not aware of the limb initially, which was known to him after someone has told to him. And for that, he didn't seek any medical advice. And he was able to do his regular activities without any difficulty. But for the past 3 years, patient is having painful limb. It is affecting his regular activities in terms of difficulty in squatting and difficulty in sitting cross legs.
So the problem which was existing in the early childhood, I mean late childhood, was aggravated only for the past 3 years, sir. That is the inference we get from his presentation. Anything, sir? Shall we proceed with the examination, sir?
Sir, sir.
Yes.
On a general examination, patient is conscious oriented, well built and well nourished. There is no pallor, icterus, cyanosis, lymphadenopathy, pedal edema. There is no neurocutaneous markers. The chest expansion is found to be 5 centimeter. On examination of the
any
hip
ligament
joint.
laxity? No laxity. Okay. You mentioned that.
Yes, sir.
Okay.
Arm span and lower segment and
Okay.
on examination of the hip joint proper. On examination of the hip joint proper, there is no exaggerated lumbar lordosis.
Louder, please.
The right side anterior superior iliac spine appears to be at the lower level when compared to that of the left side anterior superior iliac spine. The attitude, the hip in patient in supine position, hip in extension, knee in extension, with patella facing upwards and the roof, and foot and ankle at the position of ease. There is a obvious muscle wasting present in the thigh and the calf region. The right upper limb, right lower limb appears to be short when compared to the left lower limb. There is no fullness, scar sinuses or dilated veins noted in the Scarpa's triangle, and there is no scars, sinuses or dilated veins at the level of greater trochanter, and the greater trochanter appears to be at the higher level in the right side when compared to that of the left side. There is no scar sinuses, dilated veins in the medial aspect of thigh, and there is no swelling noticed over the posterior gluteal regions.
Ask him to turn and show that. Okay. Yeah. So posteriorly, you are looking for any
mass in the gluteal region and posterior superior iliac spine are at the same level.
Okay.
So if you observe closely, there is a asymmetry of gluteal fold.
Gluteal fold, yeah.
So that's one of the commonest causes muscle wasting. Okay. So the one point I want to again clarify from you. You said the IS at a lower level.
Yes, sir.
Is it?
Yes, sir. Right side ASA is at the lower level.
Lower level. In spite of that, you are saying that the right limb is shorter than the left limb.
Yes.
This is contrasting finding. You should be always doubly careful before giving these findings.
Okay. Yeah. Once you find a ASAS at a lower level and there is a shortening, you must be able to explain it. That's what. Okay. Shall I ask him to proceed, sir?
Yes, sir. Yes. Normally, when AS is at a lower level, we expect the apparent lengthening. Okay. Here you are giving a apparent shortening. That too, you clearly mentioning in inspection that the trochanter is migrated upwards, where we wouldn't see the trochanter at all in inspection. And you are boldly saying that the trochanter is at a higher level. I don't know how you could make trochanter in inspection. So these 2 points you have to explain when you are coming for final diagnosis.
Lower level, no? So
on inspection, by looking at the supratrochanteric obliteration of the
suggest whenever you are having this kind of confusing picture, so relax the patient a little bit. Again, ask the patient to lie down. Again, observe the ASAS. To me, the ASAS appears to be at the same level from here, but I'm not sure. What you are saying is correct. The patella is at a higher level. The right lower limb is shortened. But I don't know. Yes, proceed.
confirmed by palpation. There is no exaggerated lumbar lordosis. The right side anterior superior iliac spine is at the lower level when compared to the left side, and there is no swelling noticed in the there is no warmth in the Scarpa's triangle. The base of the Scarpa's triangle, there is tenderness present over the base of Scarpa's triangle, and there is no the femoral pulse is felt equally on both sides. On palpation of the greater trochanter, the right side, the greater trochanter on the right side is at the higher level when compared to the left side. The surface is smooth, regular, and there is no broadening or thickening. There is no petrochantic tenderness present. There is no palpable mass in the gluteal region.
So according to you, there is no tenderness in the trochanter. Is there any transmitted tenderness? When you say there is a tenderness in the joint line.
Bitrochantic.
So according to him, there is a joint line tenderness on anterior palpation. On lateral palpation, there is no trochanteric tenderness, but there is a transmitted tenderness to the trochanter. Bitrochanteric tenderness is present. Okay.
On coming to deformities, there is a fixed abduction deformity of about 10 degree with further abduction up to 30 degrees. Movements, the hip flexion, the normal side ranges from 0 degree to 100 degree with pain in the terminal range of movements and extension to about 10 degrees. The internal and external rotation is completely restricted.
Can you demonstrate the?
Have you compared the extension of right hip with the left hip?
Yes, sir.
Both are having same value, or
yes, both are having 10 degrees.
Same 10 degree extension.
Yes.
And you are saying that there is a 10 degree of abduction deformity.
Yes, sir.
Is it?
Yes, sir.
And further abduction is 30 degree, and there is no rotation deformity.
Yes, sir.
That's what you are
rotation
saying.
is not possible, sir. Both
No
internal and
rotation
external.
possible.
No, sir.
Okay, you demonstrate rotation.
Yeah. First do it on the normal side, then you always do the rotation in supine position. Flexion of hip 90 degree, flexion of hip, knee 90 degree. Okay.
Internal rotation and external rotation are normal.
Yes.
Okay.
Sir, on affected side, on attempted movement, the pelvis straight away starts moving.
No, it's not at all tilting. You are able to do the rotation at all, clearly.
Now it is not tilting. What is the amount of rotation now?
This is a free rotation available.
Yes, yes. There is definitely a free rotation is there. Agreed. So on which rotation is the pelvis is tilting?
For an internal rotation, the pelvis.
You tell. No. What is the?
For internal rotation, the pelvis, there is no internal rotation.
No internal rotation. There is some amount of internal rotation. Okay, there is no fixed external rotation deformity. There is some amount of internal rotation. 10 degrees available. External rotation seems to be near normal.
Yes,
these findings you are getting in with hip inflection. What about hip in extension?
Extension. Now you do it in extension.
Again, you can see.
No.
This is a rough way of estimation. Again, you can see it is equal to the normal side, this external rotation. Now do the internal rotation. Yes, but since the patient is having reasonable hip flexion and extension, you have to do it in prone position. Then only you can very well see the difference in rotation. Now you are doing it on the normal side, I assume. Yes. Yes, yes. There is no need to put your hand in the pelvis. This is a reveal deformity. The pelvis itself will tell, that will be seen by our eyes. So there is no need to keep your hand there. I closely observe what happens. So the internal rotation is almost zero. Is it? Okay, then go for external rotation. Yes, yes, that's all, that's all. So here it is getting around only 10 degree, 20 degree. Okay. So the observation from here is external rotation with hip in flexion is more than with hip in extension. Sir, agreed, sir?
Yes, sir.
Hello?
Yes, sir. Yes, sir. Agreed,
Yes,
sir.
yes. Okay. So there is a differential rotation. If you observe, there is a differential rotation.
Differential rotation is there, yes.
Flexion, we get some amount of internal rotation and a little bit extra amount of external rotation. Whereas with hip in extension, there is no internal rotation at all, and the external rotation also getting grossly reduced. That is the finding I am observing from here. So this is very, very important finding.
Yes, sir. That means there is some interarticular problem is there. The
Yes.
head of the femur, yes.
So this,
Is there any
this
axis
is very
deviation?
important. This will get aid.
On flexion, is there any axis deviation?
No, sir.
So,
Because the external rotation is not fixed. He is coming up to neutral and 5 degree internal rotation is possible. I think the axis deviation is absent in this case. Probably.
yes.
Terms of measurements, there is an apparent shortening of about 1 centimeter and true shortening of about 2 centimeter. On measurement of the Bryan's triangle, there is a supratroch.
No, wait. There is a apparent shortening of 1 centimeter.
Yes.
And true shortening of 2 centimeter.
Yes.
But you are given a value of fixed abduction of 10 degree.
Yes, sir.
Is it? So how are
Yes,
you
sir.
going to compensate this?
Sir, the Bryan's triangle, there is a supratrochanteric shortening of 2 centimeter. The measurement of Bryan's triangle.
Okay. No. What I'm asking is, so once you square the pelvis,
yes,
so this abduction will be corrected by the limb length.
yes.
Here you are giving. That is the real issue in this patient.
Shall I ask him to demonstrate the abduction movement also, sir?
Yes, sir. So you again recheck your abduction whether there is really any fixed abduction deformity.
Yeah. You check the abduction again. You do the abduction on the normal side. And as Professor said, you try to lock the normal limb. Hang it down. Yeah. Now you look for the range of adduction, abduction in the A size at the same level, no? Keep the A size
Once
at the
you
same level.
lock that affect normal limb, there is no need to keep your hand over the spine. So
Yeah,
that
that's
now
fine.
you can relax and concentrate on you can reveal by movement of the normal limb itself. Okay, now you do the abduction, adduction on the right side.
Just verify and go to the measurement, I mean movement.
I don't
No, no.
think you are getting 30 degree of abduction in this patient. So immediately I'm bringing the limb to neutral itself, the opposite limb start moving.
So
From
abduction
what
is,
we see here.
what is the fixed abduction now?
Fixed abduction of 10 degrees.
Yeah. He said there is a fixed abduction of 10 degree. From 10 degree, as you said, it is coming up to 30 degrees, sir. The range of movement, abduction.
Yes, demonstrate. You said there is a fixed abduction of 10 degree. Now you further abduct the affected limb.
கொஞ்சம் மேல தள்ளி படுத்துக்கோங்க. அந்த லெக் முன்ன மாதிரி தொங்க விட்டுருப்பா கீழே. Just to confirm the ASI's level, then you proceed with the measurement of the abduction reduction movement. Are you able to adduct? First do that.
First you do the adduction, whether it is possible. Now you see you can getting the adduction very well. And you are getting a false value of fixed abduction. So that is the problem here. So when the findings are not matching, you always try to relook again. So that is the basic mantra in hip joint examination. So you said there is a ASA is at a lower level, you expect apparent lengthening. In this patient, you are saying apparent shortening. So this is not matching. So you have to be again, you have to check again and again what went wrong. Okay, so there is adduction available. Okay, now you see the amount of abduction. Abduction also around 20 degree. Okay, so there is no fixed deformity in coronal plane.
Coronal plane.
Accepted?
Yes.
Sir?
Yes, sir. Correct.
Yes.
On demonstration, definitely there is no fixed deformity in the coronal plane at this stage. So the position of AS is also questionable now. Because of the shortening, probably the AS position is low. You have to interpret like that only. Is it, sir?
Now what is your measurement?
Sir,
you
now
said
the
2 centimeter shortening, real shortening of 2 centimeter confining to the Bryan's triangle.
super true.
Okay, we will accept that. Okay, what about next special test?
Sir, in drawing the Nilatan's line, the greater trochanter lies above the Nilatan's line, and the shoemaker's line crosses below the umbilicus, and on the opposite, on the left side, it converges on the left side and below the umbilicus.
Okay.
The Chinese parallelogram converges on the right side. In Morris bitrochanteric line is equidistant on both sides.
Okay.
Special test. Telescopy is negative. The Trendelenburg test actually.
Since you thought there is a fixed deformity, you have not tested that.
Yes.
But in this patient, you have to test because he is having all reasonable range of movement.
Did you try that Trendelenburg test in this case?
I assumed that this has a coronal plane deformity and.
But since the range of movement is possible, shall I ask him to demonstrate the Trendelenburg now, sir?
Yes, sir. Yes, sir. You can see.
Yes,
you can go for Trendelenburg test now.
Yeah.
You can even go for straight away go for modified Trendelenburg test.
Yeah. Huh? Walking Trendelenburg. அப்படி நடக்க சொல்லுங்க. ஒரே நிமிஷம் நடந்து வருது. அது வரல கரெக்டா? So now describe the walking.
Shortly.
Is it antalgic?
Antalgic and short limb.
Huh? Yeah, antalgic and short limb gait. Huh? Is there any typical Trendelenburg? If not, saying the body.
Now do the Trendelenburg test for this patient.
Yeah, now you do the Trendelenburg test. Ask him to
modify.
Do the Trendelenburg. He can turn that side, pa. அப்படி திருப்பிடுங்க அவங்க பக்கத்துல இருக்கு. Right. You see from the A side தானே? Okay, பாருங்க. Now ask him to flex, stand on the normal side.
Ask him to flex the affected limb first. Right side.
So what is
Show
happening?
his shoulder. Show his shoulder.
So the shoulder.
Still zoom out. Ah, yes. Now you can ask the patient to do stand on the affected limb.
Yes, sir. He's not able to stand.
He is not able to so. So it's a Trendelenburg test positive.
Yes, definitely it is positive, sir. Trendelenburg is positive in this case.
He's not able to, you have to stand at least 30 seconds. So you can even try modify Trendelenburg test and look for the pressure exerted on your hand.
If he is having any difficulty in standing, you can do the assisted Trendelenburg.
Now ask him to stand on right side around. We are running out of time. Right side, right side.
அப்படியே பண்ணுப்பா. Is he putting any pressure on your?
Are you able to feel the pressure? Give mic to him.
Yes, sir.
Are you able to feel?
Yes, sir. He's putting pressure on my right hand.
Yes, yes. Okay, good.
That means it is positive. Okay. So do it on the left side. Now you feel the pressure. Is there any pressure?
No, sir.
No. So if that is the difference is there means it is positive. Okay. Right. So Trendelenburg positive. Okay. Any other
Weight
test?
also you checked. So anything else you want to add? You already given chest measurement.
Examination of spine and sacroiliac joint is normal.
Normal.
Yes, sir.
Okay. Now what's your diagnosis?
Address a
The developmental pathology, arthritis of hip, arthritis of right hip.
So you want to give a anatomical diagnosis of arthritis. From your clinical finding, which finding is favoring arthritis?
Sir, there is a joint line tenderness.
Joint line tenderness is not a sign favor for arthritis. Can be
shortening.
gynosis also.
True shortening of about
yes,
2
the
centimeters.
true shortening and fixed deformity. These are the two hallmarks of any arthritis. In this patient, you are having a
true shortening
of 2 centimeters, and there is a fixed external rotation deformity with hip in extension. You are getting zero internal rotation. Okay, so there is a rotation deformity with the hip in extension. Abduction deformity you told, but we found that there is no abduction adduction deformity. There is no flexion deformity, but there is a external rotation deformity with the hip in extension, and there is a true shortening of 2 centimeters. With these points, you are favoring arthritis. Can it be Coxa-Vara?
So what are the points for you to say it is Coxa-Vara? What is against Coxa-Vara?
There will be restricted abduction and internal rotation.
Yes. So the adduction will be more in Coxa-Vara. Here in this patient, abduction is more in this patient. So that one point is against Coxa-Vara. Okay.
Sometimes you'll get axis deviation also with Coxa-Vara.
But in Coxa-Vara, when it has gone for a secondary arthritic changes, you don't expect the first primary changes of Coxa-Vara all to be present now. Now that diagnosis and pathology has now moved on to the next stage of arthritic. So now it is all the shortening, all these things are all favoring, but you don't expect the whole thing, the abduction toleration are limited, which is in Coxa-Vara. We don't expect here because now the pathology has gone for the next phase. Okay. Even if it is not present, you need not worry about making the diagnosis.
Yes, how will you proceed? So anatomically, you said it's arthritis. What could be the cause for? It's a primary arthritis or secondary arthritis?
For arthritis, most probably the secondary arthritis due to degenerative condition in the form of developmental pathology, most probably Perthes sequelae.
So you want to give a diagnosis of Perthes sequelae. Okay, read the X-ray.
This is a X-ray anteroposterior, plain X-ray anteroposterior view of a skeletally mature individual showing the deformed femoral head with a shallow acetabulum. There is a coxa breva with coxa plana, and there is a shortening of there is a reduced joint space with
This is coxa plana or coxa magna?
Coxa magna.
When compared to the opposite side, this head appears to be mushroomed out.
Yeah. So at this stage, what classification you apply for this?
Stulberg classification.
Tell that. What the
What stage?
This
other full
post-healed stage, we're gonna use a
right side
Stulberg.
மட்டும் காட்டுங்க.
Hello?
Sir,
You are not audible. Yes?
hello, sir.
Tell.
Yes, sir.
Sir, are you audible, sir?
Yes, yes.
Yeah, proceed. So tell all the problems. What is happening to the sentence line? You said the other things, no?
Sir. A deformed femoral head in the form of coxa magna with shallow acetabulum. Shallow acetabulum with
Project the right only, not left, right.
decreased joint space.
Okay. Anything else?
You present that.
You are able to see lot of osteophytes.
Yes, sir. So what does it indicate? Presence
So
of
now
osteoid.
your clinical
Associated.
diagnosis is you agree with your clinical diagnosis after seeing the X-ray?
Yes. I think
After seeing the X-ray, you agree with your clinical diagnosis?
Yes, sir.
You have given a diagnosis of arthritis. Are you satisfied with your
Yes, sir.
diagnosis?
Yes, sir.
Okay.
Stop,
So
stop.
this is a clear-cut case of secondary osteoarthritis, probably due to old perthes. So whatever you said is absolutely correct. So in this patient, the very important point is to give an anatomical diagnosis of arthritis versus coxa vara. Again, very difficult because all points are in favor of coxa vara also, in favor of arthritis also. So you should be very careful and you should examine again and again to X-ray பார்த்துட்டு அதுக்கப்புறம் diagnose சொல்றது easy, but clinical findings correctா match பண்ணி கொண்டு வரது very difficult. So in this patient, from your presentation, features are there for both coxa vara as well as for arthritis. So which point we are going to differentiate is the amount of true shortening and some fixed deformity and restriction of adduction in this patient. So these points we vote in favor of arthritis. Okay.
Okay.
So you want to discuss management, sir? I will finish.
Yes, sir. You want to tell anything? Ask. So what is the management at this stage? So now you have to enumerate the problems. Yes, shortening. Yes, joint pain. And stability wise? Stable only. So mainly there are two issues.
Pain and the shortening.
Pain and shortenings are the issues. So how will you manage?
Okay, the total hip arthroplasty. Medial.
You want to go for total hip replacement?
Yes, sir. Any other alternative, sir?
No, total hip replacement is ideal. This patient.
Yes.
There are some difficulties in doing this surgery. Okay.
Yeah.
So that is that we'll discuss in some other class.
Yes, I think we have
Yes,
enough. Yes, sir. Thank you, sir.
Thank you so much, sir. Thank you, sir.
Both cases are
Thank
very
you so much, sir.
interesting cases. We are able to make out some points.
Thank
Sir, the mayoral people, they want to honor Dr. Padiyarasan sir as well as Dr. Thanapan sir. இருக்காங்களா உங்களுக்கு?
Thank you, sir. Thank you for very much
Yes, sir.
in this program, and this program has been taken throughout the year.
Yes, sir.
Come together.
We have seen.
Yes. Yeah, for the postgraduate sake, you have been arranged this excellent program, and it has
Yes,
been
sir.
going on. So,
Yes, sir. Once the audio is still.
Are you not audible, sir?
Yes, sir. Audible, sir. Audible.
Yeah. Okay. Okay. Thank you. Thank you.
No.
Thank you, sir. Thank you, Thanapan, sir.
Thank you,
In
sir.
future also, both MMC can join together and conduct this sort of
Yes, sir.
programs.
Yes,
Thank
yes,
you.
sir.
Thank
Sure,
you,
sure.
sir.
Thank you, sir. Thank you, sir.
I'm following. Thanks once again, sir, for sparing your valuable time and transferring the knowledge to the MMC students.
It's a pleasure, sir. Thank you so much.
Thank you, sir. Thank you, sir.
Lunch we arranged here.
ஏறமா அந்த இதை மட்டும் எடுங்க, சார்ஜர் மட்டும் எடுங்க. ஆனா சுத்தி கொடுத்துருந்தாங்க எனக்கா. எப்பவுமே நம்ம லாங்னா அந்த ஷார்ட் எடுக்கணும். ஏ முத்து ரெண்டையும் அந்த நட்டை கொடுத்துங்க. இதுல இந்த பேக் யாரையா எடுத்தா? ஏங்க இதுல இந்த கட்டப்பை யாருங்க எடுத்தா? இந்த கவர் இருந்துச்சாங்க இந்த பைய. புக்கு ஒண்ணு வச்சுருக்கீங்களா? கை கொண்டது வேணாம். புக்கு வரும் தெரிஞ்சு பைய எடுத்து வந்துட்டேன்.